So welcome to the webinar, Introduction to Dental Implants. It is a lecture being presented by Sable A. Muntean, DMD, MHSA, and we are going to begin shortly. And with that, it is my distinct honor to introduce our guest speaker this evening. Dr. Sable Muntean graduated from Florida's Lecom School of Dental Medicine, earning her Doctor of Dental Medicine and Master in Health Services Administration degrees. She then completed an advanced education in general dentistry residency and an implant fellowship at Southern Illinois University School. In 2022, Dr. Muntean became the first full-time female dentist at the St. Louis VA Hospital and is currently chief editor of Ignite BDS's Get Lit newsletter geared toward new dentists. And it is my honor to say, take it away, Dr. Muntean.
Thank you so much. I really appreciate it. I'm super excited to be here and have attendees from literally around the world. So let's get started. Like Jessica said, I have a lot of content. It was just very hard to try and cut things out because there's just so much that I want to share with you all. So I really hope that you enjoy it, and I look forward to any questions that you might have at the end of the session. So as a big thank you to National Dentex Labs. And then I have the disclaimer over there that I don't have any financial interest in anything. So one more time, thank you, NDX, for having me here today. So just to introduce myself a little bit more, these are my beautiful, wonderful parents. I was very thankful to have the opportunity to go to Lecom School of Dental Medicine, and I simultaneously graduated with the Master's in Health Services Administration as well as my DMD degree. So had the honor of having my dad hood me and everything, and my mom cheering me on. So, very happy to be able to follow in my dad's footsteps as well, because he is also a dentist, and I think he's actually on this right now too. So I went to Southern Illinois University and did that AEGD and the implant fellowship. So I just couldn't help myself, and I constantly wanted to learn. So that's where I was able to get a lot of the foundation of the implant education that I'm able to share with you all today. This was actually a really cool case that I was able to do using Navident. It's a program where if you see, like, I'm not even looking at the patient, I am looking at the CBCT, and basically in the corner, there's this target, and you have the handpiece hooked up and the patient hooked up with all the sensors, and you are able to use that target as a bullseye, and you perfectly fit the handpiece in, so you drill in the right place, and kind of like how Yomi is doing things, if you guys have heard of Yomi. And it was a very interesting opportunity to have at SIU in placing implants. This was where I did private practice for a couple of years, and then this is where I work now at the VA hospital over on the 9th floor in St. Louis. And last year, I was chosen as one of the ADA's top 10 under 10 award winners amongst these also amazing dentists. So super honored to have earned that, and had the pleasure of having my parents cheering me on there too. So just very proud to be a dentist, very proud to be able to lecture as well, and just enjoy the dental life. And if you are interested in learning more, each week I come out with this Get Lit newsletter, and feel free to register. But it goes out to over 22,000 dental professionals, and there's a lot of really cool sections, so I hope you can take advantage of that. So let's get started. So 48% of adults aged 20 to 64 have a full set of permanent teeth, excluding third molars. So that's a lot of opportunities for you to be able to place dental implants on people. As most of us know, the most common tooth to need to be replaced is first molars. And, I always try and explain to patients, your first molars come out when you're about 6 years old. You have those lower front teeth that also come out at about 6, but you're likely brushing those a little bit better than those first molars, and that's why that is the most common tooth for you to lose or get, some sort of larger restoration on it. So, those can be pretty predictable depending on the extraction, but that's why it's really important for you to be able to extract the tooth properly, which we'll get into in a little bit. There are an estimated 40 million Americans who are missing all of their teeth. Now, that is a lot of opportunities for those 2-implant overdentures, okay? Actually, in Europe, it is a standard of care to do a 2-implant overdenture if someone is getting a set of dentures. So it is something that a lot of us Americans can take advantage of and be able to help our patients with that retention. And I'll get into a little bit of how I explain to patients what the benefits are of having those 2-implant overdentures. So objectives for tonight, learn how to integrate dental implants into a practice, understand the material options available, and implement a streamlined and efficient case planning process. So this is how I hope that all of you leave, I want you guys to feel like when you take your first implant course and make it your whole personality, this is what you're looking like, and this is how you're going to be able to be successful, and just kind of know, the do's and don'ts, and create a nice solid foundation. So let's talk about options we have with dental implants. So we have our single tooth where we're replacing, like I said, usually it's a first molar, but I would definitely suggest that you start with a premolar in the maxilla. That's kind of a good starting point if you're going to place your first implant. Easy to see, easy to handle. The bone's a little bit easier to work with. So just, a little pro tip. We have implant-supported fixed partial dentures, also known as bridges, implant-supported removable partial dentures. So this is where we have our regular partials that we know of and maybe add a couple implants to try and help out the situation and stability and get rid of some clasps. And then full arch prostheses where we have tissue-supported implant retained. So that's our locator overdenture, and implant-supported implant retained, which is our bar overdenture, conus, spark erosion, locator FTX, and hybrid. So I'm going to go into all of these. So imagine seeing this patient on Monday morning, okay? So this is Bolingo. He's a gorilla. And Dr. William Geyer, who's one of my mentors, he actually he sees human beings, but he also sees animals at Busch Gardens. And he had this patient come in, and Bolingo had an issue with a canine, and the canine had fractured, and unfortunately that canine needed to be extracted. So what are you going to do in this situation? Hopefully you don't have a gorilla coming in Monday morning, but when you have a patient who loses a tooth, and you have no choice but to extract that tooth, are you going to leave that hole just sitting there as is? Are you going to place bone in that area to preserve that site for the future, whether it's a bridge, whether it's an implant? Will you extract and immediately place an implant? Is that a good idea? That depends on a lot of things. Was that tooth infected? Are you able to clean that area? Are you able to get primary stability when you place that initial implant? Are you going to cover it? Are you going to put a healing abutment? I mean, there's just so many things that you need to take into consideration when placing a dental implant. And will you delay placement? So like I said, with a cover screw, are you going to place that cover screw, put, the tissue over it and let it heal? Are you going to just put bone and let that heal for a couple of months and then go in and place an implant? You have to be able to have this knowledge in order to really gauge, what you can do to create predictable dentistry. Studies show that after day 38 is when there's osteoid in the socket and epithelial coverage. So that's kind of a good statistic to know for your patients when they ask, when is this going to heal? When is this going to be okay? So you have a tooth extracted, and it usually takes about 5 weeks for that area to close and be able to feel more normal, so to speak. Okay. So, should you be placing an implant immediately after 5 weeks? I would tell you no. I would wait, until about that 3 to 4 month mark, even longer, if it's a maxillary tooth, because you want that bone to be able to solidify and get what is needed for it to successfully integrate that implant. 2/3 of bone loss occurs within the first 3 months. So it's really important for us to preserve that site. There's absolutely, I personally think that standard of care should be placing bone. Just like standard of care should be using a CBCT for an implant. I feel like whether you're leaving that site alone, whether you're doing a bridge, whether you're doing an implant, there's absolutely nothing that can go wrong, so to speak, that will hurt if you place bone in that area and preserve that site. You lose overall 50% of the ridge width, and that's more in the mandible than the maxilla, after you have a tooth extracted. So, then you have to look at if you're going to place an implant later on because of finances or whatever that may be, but you don't have that ridge width anymore, or you have a buccal deficiency, are you going to be able to place that implant predictably, or do you need to build that ridge more outwards? Major changes in the extraction site occur during the first year after tooth extraction. So things kind of stabilize after that first year. But again, that's why it's better to extract and immediately place bone instead of just extracting and seeing what happens. So again, to bone graft or not to bone graft, my answer is bone graft. Here's just some examples of how that looks. I usually describe it to the patient as grits. That's kind of what it looks like. And over, the bone graft material that gets placed, you definitely want to put some sort of collagen plug, collagen membrane, and then be able to suture that, usually in a figure 8 fashion. And I always like to add a little bit of cyanoacrylate, also called glue stitch, I basically describe it like a crazy glue for the tissue to kind of seal all of that over and keep the patient from playing with it too much to ruin what you just did. Here's an example of when, an implant is placed and then you're putting bone to kind of help out with that buccal deficiency. So, a lot of people will ask what kind of bone you want to place. DFDBA, so demineralized freeze-dried bone allograft, which is osteoinductive. That's, typically the go-to type of bone that you'll want to place. But I'm just kind of going over the surface of these things because, we can make a whole new presentation on this. But I want you guys to kind of get, exposed a little bit to some important points. And more than happy to talk later if you have more in-depth questions. So again, pre-bone graft, after graft, final implant placement can be a lot more predictable, a lot better outcome for that patient if you kind of do things the right way from the get-go, because it'll only make your life easier. Bolingo, unfortunately, was not able to get an implant placed because his root was too long. And there's no implant except maybe at Home Depot, some screw that can help for that. But he's doing fine with his 3 remaining canines, so nothing to worry about. So let's talk about crown down mentality. So when you place an implant, you have to think of you can place an implant anywhere, to be honest. Obviously you have to make sure that you're not placing it into the sinus, you're not placing it into a nerve, stuff like that. But, it's a lot easier to place an implant and a lot harder to restore that implant depending on how you place it. And so you really have to, when you're planning that implant placement, think about, okay, if I have, this deficiency in the ridge, or I have a lingual concavity, or, my spacing between the teeth, where am I going to place that implant predictably so that the crown that I make afterwards will be the proper contour, be able to have the proper occlusion on it. So the force is going down the long axis of the implant so that I can maintain that implant and be able to create a good life for that implant. Because if you place it and then restore it. And that because that placement was poor, the restoration had to be forced to be made a certain way that cuts down the life of that implant, you're going to have a very unhappy patient. So please always think about, that crown down mentality of, okay, if I place this implant at this angle, will I be able to make a nice restoration for that patient that will be successful and hygienic and everything else that we know that an implant needs to be. So let's talk about that single tooth. As we know, there's 3 parts. So the implant itself is that screw or that post that goes into the bone. And then afterwards, we have the abutment, which is that connecting piece between the implant and the crown itself, which was what the patient sees. And there's stock abutments, there's custom abutments, but again, that's a whole other conversation that we can, maybe have a part 2 for. So remember, place to be able to restore. You want that occlusal forces to be able to go straight down that dental implant, because it's not like regular teeth where we have a PDL and, we're able to, even though actually now that I think about it, that picture looks like it has a PDL. But we don't have that PDL, which acts like that shock absorber for us to be able to have a patient bite down on cusps. We want that force to be straight down the center of that implant so that we're not putting forces on that implant in different directions that would cause it to loosen and ultimately fail. So let's talk about a timeline of how we need to think about, when the patient presents and how we should plan accordingly. So our stage A is to evaluate the patient, do diagnostic casts, and take a CBCT. We want to review their medical and dental history. We want to ensure there's no smoking, that they don't have excessive sugar intake, that they have controlled diabetes if they are diabetic. Key thing is more of the HbA1c to be under 7.0, excessive alcohol intake, and no bisphosphonates, because obviously we don't want to deal with osteoradionecrosis. So here I kind of go into those red flags a little bit more with our smoking. We don't want the patient to have periodontal disease. A lot of people just think that implants are the answer to everything. And honestly, after being, in the fellowship and whatnot, I've learned that, implants really aren't the answer to everything, and they're not the answer that, I know a lot of patients, want to hear, oh yeah, I'm just going to place an implant, everything's going to be okay, but so much can go wrong. And there's so many patients that it's just not the right solution for them. And we really have to be able to explain that to the patient and have that confidence in ourselves and not, push it to the limit. No bisphosphonates as discussed, no uncontrolled hypertension, excessive sugar intake, and the alcohol. And another one actually also is bruxism. If that person is grinding, if they're not willing to wear, I always prescribe an occlusal guard after implant placement. Well, after restoration, rather, of an implant. And because you want to protect all of those teeth, because the implants don't take the same forces as the regular teeth. And especially if someone's a bruxer or a clencher, we definitely want to make sure that they're minimizing those forces, especially when they're unaware that they're doing them. So this was a great one that I had. Make sure that you're asking your patients in depth, questions of what their medication list is. And, I had this patient that came in and said they take ibuprofen and Tylenol. So, make sure that you differentiate and you ask the questions, and don't be afraid to ask questions in different ways. So, for instance, I had a patient come in private practice who, I asked her, I said, do you, she literally had a check for $13,000 in her hand to give to me to place, some implants on the lower, and to help with the retention of her denture. And, but something in my gut was just telling me that she just wasn't a good historian. And I asked her, are you taking any bisphosphonates? And she said, no. I said, okay. But I knew that it said something on her medical history about osteoporosis. And I said, are you taking anything that helps with bone growth or, stabilizing your bone? And she's like, no, never, not taking anything. And I said, what about, anything that gets injected? And she's like, oh, actually, I do get this injection once a year, and something to do with bone. And I just, cringed. I'm like, well, here's your check back, because I'm not touching you. And she was taking reclassed, and through, IV. And so, I checked with the oral surgeon and everything. He's like, I wouldn't even touch her myself. So unfortunately, implants were not a good option for her. Make sure that you're documenting everything, clinical findings, periodontal charting, oral cancer screening, evaluating that joint, because a patient's going to be open for a while, especially if you want to be placing an implant on the second molar. Make sure that they don't have any clicking, popping, discomfort upon opening and closing, because if they start developing that afterwards, you can very easily, get blamed for that. Doing a load test, checking their maximum opening. That's a really good opportunity for you to see if you want to send them to the specialist or not, if they can't open very well. And very important, checking that there is enough interocclusal space. A lot of people just kind of look, they see a little hole and they're like, oh, perfect, I'll just place an implant there. But they forget to have the patient close. And like I said, sure, it's easy, so to speak, to place an implant, but can you restore that implant afterwards? Is there enough space for the parts and pieces that you need to be able to restore that implant? So there's different measurements that you need for cement versus screw retained. So a screw retained, you need at minimum 4 millimeters. So that's going to give you enough room for that stock abutment and for that crown that's going over. I always, always, always try to do screw retained if at all possible. I want to be able to access that implant afterwards if, God forbid, I need it. And, there is a higher chance of failure with a cement retained. Yes, you try to clean it and put as little cement as humanly possible. But there is that chance, that you're going to get the cement in there and cause peri-implantitis. Also, cement retained, you need more room for some more parts. So you need the 7 millimeters minimum of room. And then there's screwmentable. So screwmentable, you kind of do it chair side. And so you're able to try in that custom abutment. It comes separate from the crown itself. You still have that access, it's kind of like a blend of screw and cement retained. And you cement that, you can do so outside of the mouth so that you keep it clean. But it can also be a cost saving situation for the dentist. And you still only really need those 4 millimeters. So let's talk about placement. So as we know, there is a very typical textbook picture, which is not this one, just a little funny joke here, but this one of our implant placement. So implant to implant, you want at least 3 millimeters of bone in between. You don't want those implants to be touching, or else you have a higher chance of issues coming from there. You want at least 1.8 millimeters, 2 millimeters of buccal bone. And implant to tooth, you need at least 1.5 millimeters to avoid resorption of the roots. So remember how I said place to restore? Okay, so this was an implant that came to, or an implant crown that I had to deliver. The patient needed a new crown, and the implant was already placed, and this was the only option. And we call this a diving board. And so the implant was placed in this, general region, and the only option for that crown was to be made like this, like a diving board, and have that huge platform. Do you think that she accumulates a lot of food in that black triangle over there? Definitely. You have a much higher chance of failure because of, the implant being able to turn on its side a little bit. It would have been much better if that implant was placed in that general area, and then be able to make a nice contoured implant crown, and be able to have a happier patient, a longer life for that implant. So, things happen. Not everyone is perfect, and, it is what it is. But definitely on a patient like this, you want to be able to have, just like with any implant, but a very broad contact between the teeth, so that, you can even sometimes need to make a little guide plane over here, so that you minimize those areas where you can create some forces that you don't want on the implant. And you want to be checking that occlusion, especially at hygiene appointments. Every 6 months, have that patient sit back for a second after the hygiene appointment and check the occlusion on that implant, and make sure that they're still going straight down the center in that long axis. You know, this is a patient that came to me who has had this implant for a number of years. Hey, it worked, but you have to look at where the bone is. You look where that implant was placed, the bone's all the way down here. Look at that crown that was made. I mean, imagine just seeing what that custom abut or, you know, abutment looked like. But patient was happy, but he said, he's like, yeah, they failed this, you know, 3 different times. And this is the last time that they've done it. And, you know, so far it's looking okay. So it's wild what you see. You know, sometimes, like I said, implants are not the option, are not the best option, and you might need to think of something else. So we've looked at interocclusal space, and now we want to take extraoral and intraoral photographs. So this is the camera that I use. It's my Canon 90D10. And I like to take pictures of everything, and or 90D, not, I don't know why I said 10, 90D. And I like to take pictures and be able to look at stuff, you know, on my own with specialists, with my dad. So you want to be able to take a full face photo, a profile smile, a full smile up close. Then you can obviously tell why I was taking pictures of this patient. He wanted some implants on that lower area. The rest position, okay, so that's where you have the patient lick their lips and say Emma and just relax, and you're able to see, you know, how much tooth you're able to see in that rest position. Front teeth retracted with the teeth together, front retracted with the teeth apart. Right lateral retracted, teeth together, left lateral retracted, teeth together. Your upper occlusal, lower occlusal, we can get a better picture of that. Here I was also helping with the train the assistant. And any additional photos that you need. So here we can definitely see that we've lost a lot of the ridge, and, you know, definitely the CBCT is going to help us to see how wide of an implant we can place. Do I need to rebuild that ridge a little bit and expand it in order to be able to place a more predictable implant? So we've taken our pictures. We're going to look at doing analog or digital impressions of the upper and lower arches. So we have our regular alginate impressions. We have with PVS, you know, you want to be as accurate as possible. So, you know, whatever floats your boat. These are actually my teeth. And these are my teeth as well in a digital format. If you quickly notice, I have 3 premolars. So actually the third premolar, most posteriorly, is a dental implant on both sides. So fun fact over there, when I had braces, they pushed my upper teeth forward to create more space for my airway, and that left 2 spaces in the back that happen to be perfect for dental implants. So that's in a way nice that I can, you know, relate to the patients and say, yeah, no, I totally get this. So yeah. Take our bite registration, centric relation record, Facebook transfer, and the very important CBCT. So why is a CBCT important? Because we need to see where those anatomical structures are, our nerves, our sinus, and make sure that we're, even during implant placement, you know, you can take a CBCT and see how everything is looking so that you're angling everything correct. Because I remember in my fellowship, I had one which, you know, it just looked perfect clinically, like no problem whatsoever. It was right dead center, you know, into the space that I had. And then I took a CBCT and it looked like it was just about to come out of, there was like a lingual concavity. I think it was number 19. And I'm like, oh, thank God that I stopped, you know, but you just never would have thought it from the angle. And I remember even my professor coming over and he's like, there's no way to place this properly in the situation that we're in. So yeah. And you know, you definitely want to be able to walk around the patient, look at that patient from every single angle and make sure, you know, use your assistant, train your assistant to be able to also see, because they see things from different angles than you do, and make sure that, you know, this, you know, the angle of this is coming out the right way. It's coming across the central grooves of the teeth, you know, because again, you want to have that nice, profile and be able to occlude on that implant properly once you put the crown over it later on. So that was after the implant was placed, so safely away from that sinus, and had a happy patient. Here's, you know, you have your 2D x-ray and you have your 3D x-ray. Everything looks great. And then, So, again, you know, it's very important to be able to take a CBCT when you're placing dental implants, because you just really don't know what can go wrong until it goes wrong. So talk about your finances and timeline with the patient. Make sure that they're well aware of everything. And then have, you know, an implant coordinator in your office that discusses the treatment plan presentation, which, you know, or reviews it rather, because you've already discussed it, and discusses that payment. Fabricate your guide. And then, you know, then we come to surgery day of, where again, we place either a cover screw or a healing abutment, like I mentioned earlier. This is a template of one of my notes. You're more than welcome to message me later on, and I'm more than happy to share that with you. And you can see all the different things that I incorporate in my notes. So immediate post-operative care, we want to make sure that we minimize the contact with the implant and make sure that you tell the patient the stability of that dental implant, because that dental implant should not be touched at all between the weeks of between week 4 and week 6, because that's when that implant stability dips, because the bone is remodeling. And you know, even though we have that initial torque, which is great, it's going to dip down between that 4 to 6 week mark, and that's when that implant can fail. So make sure that that patient doesn't have a hygiene appointment around that time either. You definitely want to be extra careful, and limit foods to soft items and chew on the other side during that 10 to 12 weeks of integration. So here's just a little graph for you to see that stability dip that I'm talking about. So you get that primary stability in the old bone that you have, and then around that 4 to 6 week mark, there's that dip, while that secondary stability is being accrued with the new bone coming in. So single tooth, we've discussed more about it, and we'll show, you know, I'll go through just an implant placement so you can get that idea. So this was a patient that came in to one of my associates, and anterior implants are very difficult to place. So I would not suggest starting with that, because you need that buccal bone. This was a patient that, you know, took a lot of convincing in order for me to place that implant, because of that crossbite, because of the patient, well, I can't think of the word right now, but you know, how apt they were to following directions. We were not able to place an implant on that upper right because the sinus was just hanging way too low, but he was just very insistent on getting that implant on the in the front at number 7. And my associate was going to place a couple of crowns and play with the bite a little bit. And I was like, you know, as long as, you know, I'm not the one responsible for that restoration, by all means, you know, here you go. And so here was the implant site originally. And you can see there's a lot of, you know, bone over there. It's very thick. It's a nice area. There's a little bit of a dip in that facial area. And but again, you know, pulling everything back, doing that initial flap, I was able to see it very nicely, and say, you know, yeah, this is good. And obviously I looked at the CBCT and all of that stuff, and I was able to predictably place an implant there, that of course would be very much out of occlusion. So here I placed that implant, the pilot guide. And so that's how I was trained. There's you know, your stackable guides, your surgical guides, you know, you can have a fully guided surgery. I learned off of a pilot guide, so I make that initial mark, and then for lack of a better word, freehand the rest of it. But I do create that flap so I'm able to really visualize where the bone is and everything. And here I'm looking at it in different angles. I'm seeing that I placed it nicely. I have that 2 millimeters of buccal bone. I am looking at, you know, where that implant is coming out of. I want to make sure that it's coming out of the cingulum, because I want to be able to, so you can kind of see here, if I were to draw a line over here, that it's falling where that cingulum is, so that the pressure is put properly on there. If I look back at it, you know, sure, I could have added a little bit of bone over here to kind of build this out more. But as you saw in the CBCT, I had those 2 millimeters. So of the buccal bone. So it wasn't that crucial of an issue, but sure, you know, in hindsight, that wouldn't have been a bad idea. But the patient was just super excited to be able to have something there. You know, I was happy to oblige in that situation. So now let the patient go and go from there. So with him, I just did a cover screw. I did not place a healing abutment because I didn't trust him and not touching that area. So again, you really have to trust that patient in order to place that healing abutment and make sure that they're not, you know, chewing on any nuts and stuff like that that are going to put a pressure on that implant. So I have the patient come in a week later, check on them, check on the sutures and everything, take a PA at 1 month, take another CBCT at 3 months to make sure the implant's integrated, looks nice. Do that uncovery if I need to, allow the tissue about 2 weeks to heal, take the impression, analog or digital, and then deliver the crown or whatever prosthetic it might be. Parts needed for an impression. So you have either open tray or closed tray. You have a scan body if you're doing it digitally. And this is kind of what the scan body looks like when you take that digital impression. Pro tip, you want that notch, that bevel in that scan body to be towards the buccal. So buccal, bevel, bevel, buccal. It just helps the camera capture it better. And then you have your impression analog, also called the replica. So that just shows exactly what that implant looks like. I will take my impressions the analog way with a medium body because I want it to be a little bit more rigid and I don't want chances of something changing when that impression is being transported. So here's a case of number 30. This implant, she was part of a study that my implant fellowship was involved in, and of extraction immediate placement of a Southern implant. And 66-year-old female, class 3 mobility and foul odor of that number 30 tooth, perio depths between 6 and 11. So obviously we know there's a fracture in there. That tooth was extracted. We can see the where that root was fractured. I took that out and then I placed a Southern Pro Max dental implant, which is a big implant. Okay. So this one was an 8x9 millimeter implant. And this is putting that scan body in. We scanned it and then afterwards put a peak abutment over it because part of the study was then to send that scan to the dental lab, and they made a temporary crown over that, and we put that in there and then saw how that implant did and integrated. So this is what it looked like afterwards. That was not a deficiency in the bone or infection or anything like that. It was all cleaned very, very nicely. And yeah, as you can see, that was a big boy. So yeah. This is another patient. The only reason that I wanted to put this in was, you know, yes, you can see it's an implant bridge, but you can see that guide plane that needed to be made over here. So he had a bigger bridge and that got sectioned, but that guide plane will really allow for a proper contour of your final restoration so that you have less areas to jolt like that. Okay. Another tip is taking a vertical bite wing for verification purposes. So a vertical bite wing, you're able to see more and you're able to see straight on instead of a PA where you're taking it at an angle and you can think that something is seated, but it's not actually, because you can't see where the base of that crown meets the actual implant itself. So I take vertical bite wings for impression coping seatings, custom abutment seatings, and making sure that the cement's removed. Never torque anything except for the final screw. I cannot emphasize that enough. So, you know, you don't want to pick up that wrench at all until you're done, okay? And you're giving that final implant. So just a quick review, because a lot of people don't realize this. There's a lab screw and then there's the custom screw for that actual implant. So here's an example of a case I recently delivered. So usually that final screw is going to be gold and the lab screw is going to be silver. And the reason that I bring this up is because that lab screw, if you see, it has gunk on it because that's been tried in and out for the lab to be able to make that crown properly, as opposed to the custom screw. That's your final screw, has never ever been touched. It's never been turned. It's never been anything. So you want to make sure that you're not delivering that final crown with the lab screw and you're doing it with the final screw that your lab is supposed to supply. You don't know what you don't know. I can't express this enough, especially, in this lecture of, intro to dental implants, don't bite off more than you can chew. This was a patient that came into me in private practice. She went and had these implants placed outside of the country. No, I know a lot of people poo-poo, people from, dentists from outside of the country, but we all came from somewhere. And, there are very talented people, outside of the country as well. And, but in this situation, she went to multiple people in the US who kept telling her no. And so then she went outside and she got a yes, and this is what happened. And it's just a funny story. Her chief complaint was that in this lower left-hand corner, she could see some metal from the thread of the implant being exposed, and she wanted all of the crowns in the entire mouth changed so that that metal wouldn't show anymore and everything would be more even. And I even told her, she's like, oh yeah, I know I needed to raise my VDO. And that's why they told, I forced them, like the outside office, they didn't want to do these crowns because the crowns were bigger than the implants. And I'm like, so, red flag, red flag. She's using all of these, VDO and understanding the crown length, the, ratio and stuff like that. And I said, you know what, ma'am, I think, it would be good for you to get the opinion of a prosthodontist. And so I referred her out. But again, know where your limits are. Don't touch a tooth. It's not worth it. It's just not worth the headache. There's a group, which is just interesting to follow on Facebook. It's called Dental Implant Discussions, and it's basically patients posting things. And, it's just interesting to read, what their questions are, different issues that they're having. And this was a patient that made me really sad to see. So it looks like there's some sort of membrane, and then there's a healing abutment over that membrane. And you can just see, that implant was placed horribly up there. And it's just not going to be a good time to restore. And honestly, I would take that entire implant out and bridge, create nice tissue in that area, do a bone graft and everything, and see what other options there are. But again, don't bite off more than you can chew. And take a closer look at this one. This was another patient of mine that came in private practice, and I almost, spit out my coffee that morning when I saw her, and I saw this panel be taken. And if you notice, you see quite a number of no-nos. 2 implants got placed, and we have an implant to a natural tooth, root canal treated, bridged together. So I went up to this patient. I asked her, do you know, does anything feel weird to you, in your lower left-hand side? She's like, no, I have no problems. And she had no clue that she had 2 implants there. What I'm assuming happened was the dentist forgot to change the speed when they went to place that implant. And it went straight through, and then they made a 2-for-1 deal. So I took a CBCT because I just had to see what it looked like. And hey, the saying, if it fits, I sits, and it fit and it sat. So, 10 out of 10, don't recommend this. But be very, very careful. So key takeaways: preparation is key. Diagnostic cast photos, medical and oral health, patient expectations. You want to make sure you have all of those under your belt. When placing an implant, envision your outcome and know your limitations. So I am going to really speed up with these next parts of going into these other prostheses, and then look forward to some of the questions I already see coming in. So a little bit about implant supported bridges. So we can even do a full arch of this, okay? So typically you want to have, I would say about 8 implants. I know there's 6 implants in this one, but 8 implants in order to create that AP spread. And you can make little sections of bridges, and that's really, the nicest outcome that you can achieve when you're doing full arch on either arch. And you have your regular, 3-unit bridge, like it's on the lower. So again, never, ever, ever do a tooth to implant. You're just asking, one has a PDL, one is integrated into the bone, the forces get put on them, and you're asking for something to break because something's going to weaken. So please don't do that. And like we saw over here, that's, patient's lucky because of their occlusion, but this is one that a recent case that I had, which, it's failing, but patient's not complaining, so I'm not going to touch it until it fails, and then we'll figure it out. So here's a patient that I had in private practice. This was a challenging situation due to the interocclusal space. Okay, so I worked with my lab and I said, how can we, she didn't have success with the partial. She really wanted something fixed. And I said, how can we place these implants in a manner that we can create a nice bridge afterwards? And so basically we kind of fudged it a little bit, and we're able to put the place the implants in, but be able to create the bridge in a certain way where it didn't I was able to kind of play with someone's eye to make it look nice and follow the arch, but still have the implants and the force be placed on the implants in the proper way. So here you can see that limited occlusal space that we had, but it was kind of just enough. So I was able to place those implants along the arch. And here you can see, where those access holes were, straight down the cingulum, straight down the center. It just was a very nice placement. And like I said, we're able to kind of play with, the eyes where we were able to build out that bridge a little more buccally so that it looked more aesthetically pleasing, and the patient was very happy. Understand when, how much is too much. This was a patient I had that unfortunately she's going to an $80,000 mouth instead of a $50,000 mouth because every single time she breaks a tooth, she places an implant, and she had all 4 of these implant systems in her mouth. So, the only choice that she has is to place an implant whenever she breaks a tooth, because nobody sat down and talked with her and said, hey, we're already at that, we have about 4 implants in one arch, maybe we need to start looking at, a full arch prosthesis, because the height that an implant is placed for a single tooth is different than the height that it's placed for a prosthetic, because of the parts and the space that you need for those parts. So don't be afraid to have those conversations with patients and know when, it's too much. Key takeaways to this part: understand when it's time to discuss full arch prostheses, build a good relationship with your lab, and use every angle you can when placing implants. So let's move on to implant supported removable prostheses. So this was a patient that I had come in, who it was the owner, it was his patient, and he asked me if I could place an implant in that anterior 9-10 position. And I was like, yeah, no, because this was his a pano, and as you can see, he has 4 implants already, and 2 of them are not restored. He's had them there for a number of years. They just had healing abutments in them. And this man is about 6'8", a very big guy, and as you can see, that bruxism, breaking everything all the time, and already lost a crown on that lower right. There were just a lot of things that we needed to look at. So I said, what, let's kind of think out of the box. And, I told him, I said, you have the options of taking out all the teeth on the upper, taking out those implants, putting in, 4 to 6 new implants, and calling it a day and doing it that way. And he's like, I don't want to spend all that money, and I don't want to go through all that surgery. fair. So then I looked at another one of let's do a conus type, and I went with the lab and I said, okay, if we take, out those crowns of those implants on top, can we use the implants that are already there? And then we planned it out where we could add 2 more implants on the upper right and be able to have, the right degrees, because you can't have more than 20 degrees of a difference in angulation, and be able to do a conus. And we said we could do that, but that came out to about $23,000, something like that. And the patient was not too excited about that either. So then we came up with this other idea of how about do an implant supported RPD where I keep those implant crowns the way that they are. And therefore you didn't lose money from that. And then I use the 2 implants that are left over and have them hook onto the partial so that we don't have to use clasps around anything. And then he can have a more, supportive and sturdy prosthetic. And then add an implant over here on the lower right, put a crown over here, and then he has a lot more teeth to chew with. And that was only about, I don't know, I think it was about $13,000. And he loved that idea. And so we took out those teeth that you see that I X'd out and kept the rest, placed an implant on the lower right. You made a custom abutment for that, the one on the upper left, and then on the upper right, just had a regular RTX abutment and picked all of it up. He was wearing a Valplast partial in the meantime, temporarily, as you can see, he wore it a bit too much. And here we were able to pick it up, and he was a very happy patient. So this is a pickup material that I use that goes to the resin and attaches to resin. And here he was. Later on, the plan was to put some crowns over here. And if you just look at him side by side, it's a huge difference. And he was very happy. And all he really wanted was it for function. He didn't really care about aesthetics, but even so, it did come out with a nice outcome. So you can really see, the different things that you can do and be clever and a little bit, creative. So key takeaways: understand ways that you could be more financially savvy for your patient, be creative, and make sure you have the right materials for pickup. So last but not least, our full arch prostheses. Okay, so tissue supported implant retainers are locator over denture. So how I like to tell, well, actually, I'll pause for that moment. So we have our fixed and we have our removable. Okay, so our fixed is something that only you as the dentist can take in and out. You're screwing that in, and then removable is where that patient can remove that prosthetic themselves. There's a lot of things that you need to take into consideration for this. The smile line, okay, that's a huge thing. If you have a patient that is in a hybrid and they have a really high smile, they have that gummy smile that everything kind of comes up, and you can see that transition line, you're going to have a very unhappy patient. If that patient has a very sunken in face, okay, and they need more lip support, having a fixed hybrid is not going to be the answer for that, because you don't have all that extra acrylic to be able to build out their face. Hygiene. Fixed hybrids are disgusting when you take them off, if you ever have. So definitely, if you have a patient that is going to be taking care of the prosthetic, which is always questionable because you ask yourself, why did they lose their teeth in the first place? Then, you have to reconsider fixed versus removable. Number of implants. The saying is all on 4, none on 3. So if you have 4 implants and one of them fails, you're not going to be able to put a prosthetic over 3 implants. So more implants are better. I always suggest 5 to 6 implants. And then space needed. You need a lot more space for a fixed prosthetic versus a removable one, which I'll show you right now. So these are all the different parts that you need. I'm not going to go into everything in detail, but you need, if you were to add this up, 18 millimeters in total from the crest of the bone to where the edge of your tooth is going to be. So definitely you want all of that space, but you need to create that space, and you're going to mow down a lot of bone, which I'll show you soon. So removable, we have our locator root attachment system. This is typically our 2 implant overdenture, or obviously you can add more, but make sure that you're placing those implants at the right angle. The way that I describe this to patients is, if I were to give your denture, your conventional denture a grade, I would give it an F. If I were to add a 2 implants to the lower and attach that to your denture, you're looking at a C. And if I am going to add a couple more implants in there, now we're getting closer to a B and an A. Okay, so that kind of helps the patient realize, what expectations they should have from the addition of some implants, because you still need all of that acrylic to be able to create enough support and retain that implant and have that stability. So you have your overdentures with locators. These are your typical locators, the different strengths that you have. Always, always, always start with the lowest strength for the patient. Don't go straight to that clear one, because then you have nowhere to go from there to make that stronger for that patient. And then you have extended range inserts. So these are when those implants are placed at a different angle, and you need to they don't have the little buttons inside. And so you're able to kind of gain some more space due to that divergence. This was a case that I did. You start in that upper left-hand corner, but here how she presented, made our initial incisions to lay the flap, then go to having that pilot guide. And this is where I initially placed those 2 pilot drills, saw exactly where I was placing, made sure that the angles are nice and parallel, place those implants, double check again, triple check again, have the cover screws, suture it all over, and put a soft reline in that denture, and let the patient stay with the denture in, but try to keep the denture out as much as possible. Then you have an overdenture with a bar. So this is when you don't have to rely on the tissue so much. You can take away some of that acrylic, and you're basically stabilizing those implants. And you attach those same little inserts on there for it to clip in. Another insert is this hater clip, which allows for a little bit of rotation. Then you have your conus overdenture. So the conus is my favorite. Basically, it's a friction fit overdenture. You have custom abutments, which you see over here. And then you have these Syncone caps, which everything is custom made. And these Syncone caps fit perfectly over those custom abutments. And it becomes very, 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 very retentive. Like, you have to tell the patient to take this out a couple of times a day so that it doesn't get so stuck by the end of the day that it's extremely difficult to take out. So this was a patient that came in. She had actually a locator FTX hybrid. So the locator FTX is another one that only the dentist can take out using that removal tool. It has that ball attachment over there, but it gets very stuck in there. Now I hope you're not eating dinner, but you can see how this looks, and you can see how it looks when I take it off. But when you look on the inside, this is how gross it is. So I just really, again, and this patient is someone who is very clean. She's a nurse, was always, water pick, everything that you can think of. Obviously, there's a little bit of, the contour of that acrylic, that prosthetic. How was it made? Could it have been better so it didn't collect so much food? But still, it's just not a pretty sight. So we were able to place custom abutments and had the lower teeth crowned and everything to make a really nice smile. So here's those custom abutments. Here's with those Syncone caps that end up getting picked up within the denture itself. Here's how the denture looks, has that metal reinforcement. Here's with the Syncone caps picked up, how it looks with everything nice and pretty, and how that patient looks now. So she has that lip support now, and she has an absolutely beautiful smile that she's very happy with. So, I just really like the fact that the conus is removable. And so you don't have to worry about that cleanliness issue, because the patient can keep it clean themselves. This is a spark erosion. This one is the most expensive one because you have two milled bars. So you have your primary bar, which goes over and splints all the implants. And then you have a bar that's within the denture itself. Now, the trick about this is that if you look over here, there's a little latch that's on the inside. So you have to make sure the patient has enough dexterity, but that'll slip over the bar, and then they just close that little latch and it's very sturdy. But again, it's just very expensive because of all those additional bars. So last but not least is our fixed one. And thank you so much for being so kind and letting me speed through this because I know I'm talking at very quickly. But these are the hybrids. And so there's different ways that you can digitally plan this. NDX has the end sequence. We have Chrome, so full arch guided stability, and Straumann Smile in a box, just to name a few of the different options that you have to fully plan this out digitally and be able to implement a very nice sequence of events the day of surgery. So this is an example of a case that I did using Chrome. So this patient came in, she had by far the best chief concern that I've ever heard. 71-year-old female tells me, I want to be able to chew a pork chop because now I can only chew a filet mignon, first world problems. So she came in, and here you can already see after the implants were placed, we placed 6 implants. But basically she just wanted to do the upper arch. So this is how the stuff comes from Chrome. It comes in this beautiful box, and I have all of my guides over here. I have another denture just in case, because if I don't get enough stability, I want to be able to have the patient leave with something. I have my surgical bites. I have my temporary hybrid. I have a bone reduction guide, and this is you can see just how much bone ended up having to get reduced in order to create enough space for that for the restorative space rather. And I have all of my multi-unit abutments, my implants. I like to be very organized the day of surgery. So here is how she came in, and we first laid that buccal flap, and we're able to see all of these teeth the way that they are. And now we have to start placing all of our different guides. So this is when you get those stackable guides, okay, if you ever hear that term. So basically I put the pin guide in place. So it stops exactly where those teeth are, and it tells me just how far to push this down. And this is going to be my base over here, okay? And then there's some fixation pins that go in. Obviously, that's all digitally planned so that you're not going through any anatomical structures. And this is going to help stabilize that base. And then we just stack the guides on top of it. So here's our fixation base. And now I want you to really look at this and see, this is how much, and once those teeth are extracted, all of the bone that's going to go away, because all of this needs to be flat to that base. So it is just wild to see how much you need to take away. So here's with the teeth extracted, and now all of that bone, I mowed it down with a lovely pineapple burr. So just, a little heartbreaking. Now I put the osteotomy guide in place, and this is where I'm going to place those implants through those holes that you see, and you see the different angles because we're trying to avoid the sinus. This is how it all looks. And, I kind of go through each implant, and I'll just give you, so yeah, here you can see the little cross section of where each implant was placed, where the sinus is, and just, to make sure that we did everything proper. The implant on the upper right-hand side, I didn't get enough primary stability, so I ended up just covering it and cutting the temporary hybrid so that it wouldn't engage with that, because I wanted to keep it as safe as possible. So here was my prosthetic carrier. I'm putting in my multi-unit abutments and making sure everything is at the right angle. These are some gaskets that we put, so you can even use just a rubber dam, but these were especially made so that we block out the acrylic from getting into the areas or the pickup material. So here you can also use toothpicks, but again, just some specially made things to kind of cover up those holes. And placed in that temporary hybrid. I had made some marks on her nose prior to make sure I see where that midline is and line everything up. Here I had some healing abutments that I placed over while the lab was making everything nice and smooth after I picked it up, and I was able to suture around there. And then take all of those healing abutments off, except for that one on the upper right, and put in that hybrid. So again, this is the temporary hybrid, and you can see how it's cut off on the upper right-hand side over here. She was supposed to get that number 30 or 31 extracted because it needed another root canal, a retreatment, and she didn't want to go through that, but she was too tired after this because she had a lot of dental anxiety. And so we saved that for another day. And she was going to get a Valplast partial on the bottom. So this was 1 week afterwards. And this was her final prosthetic. So this was done during my residency. So I did not make this final prosthetic because good old COVID happened. So, but I did reach out to her later on and I asked her to take some, if I could see her and take some pictures. And so she let me, and she was bummed she chipped that front tooth over there, but you know, things happen. But she was very happy with the outcome and the stability. And here's her before and afters. And this was again with the temporary hybrid in there, the one that I did. So key takeaways: there's hardly ever enough vertical space. Measure wisely. Use analogies for your patients to understand their options and learn the various ways that you can help your patients.